change into a malignant disease. Now, what are the learning objectives to today's talk? You will, at the end of the lecture, you will be able to describe the common benign conditions of the cervix, understand the risk factors associated with these benign lesions, understand the primary prevention of carcinoma of cervix through human papillomavirus vaccination and cervical screening, and to understand the diagnosis and management of pre-malignant diseases of the cervix. The benign diseases of the cervix are common and are unusually asymptomatic, or they cause minor symptoms but must be differentiated from malignancy. Cervical cancer is the second commonest cancer in women, and it is preceded by a pre-malignant form years before its invasion. Screening for pre-malignant disease of the cervix markedly reduces the deaths from cervical cancer. So screening is very important for the pre-malignant diseases of the cervix. If we will screen the women for these lesions, we can reduce the cervical cancer. You all already know that the cervix is lined by the cervical canal, is lined by the columnar epithelium, and while the ectocervix, this is the ectocervix, this is vagina, this is cervical canal, and the ectocervix is lined by the squamous epithelium. During childhood, this area, the junction of squamocolumnar epithelium, lies inside the cervical canal. While during reproductive age and childbearing age, this columnar epithelium outgrows and this squamocolumnar junction lies outside the cervical canal. As you can see over here, the canal ends over here, and this columnar epithelium is ending over here on the ectocervix. On this side here, this is the squamocolumnar junction. And while in the postmenopausal women, it recedes upwards into the endocervical canal. The squamocolumnar junction recedes inside. So this is how this squamocolumnar junction changes its position from childhood till menopause. Now, what is zone of transformation? The area of the cervix between the old and new squamocolumnar junction is called the zone of transformation. It is the area of risk of developing pre-malignant and malignant disease of the cervix. So this is the zone where the pre-malignant lesions, they change into malignant lesions. So this is the main site of, or the focus where the carcinoma of the cervix takes place. This is the picture showing zone of transformation. This is the squamocolumnar junction, and this is the area of zone of transformation. It is here, and before it was here. So this is the area of where the zone of transformation takes place and where the malignancy can occur. Now, there are different types of benign diseases of the cervix, which is starting from cervical ectopy, which is also called cervical erosion, cervical eversion, that is ectropion, cervical tears, cervical cysts, which are called Nemothean cysts, and endocervical polyps. And last of all, inflammatory conditions of the cervix, which is called cervicitis. Now, what is cervical erosion? The etiology is it can be either acquired or congenital. Acquired can be due to hormonal imbalance, that is in pregnancy or in nocebo users. And in congenital, it may be due to and the other The cause of acquired is infection. So either it is due to hormonal changes or either it is due to infection. So chronic cervicitis may also lead to cervical ectomy, and it may be congenital. How it will present: with vaginal discharge, there will be contact bleeding, that is post-coital bleeding, or if you examine the cervix and if it touches the speculum, then it will start bleeding. So contact bleeding. It is also associated with cervicitis, may produce backache and pelvic pain. Signs include on birth spectrum examination. When we do spectrum examination, there will be bright red area extending beyond the cervical os. And it is neither tender nor bleed on touch. Outer edge clearly demarcated. The feel is soft, granular, and gives rise to a grating sensation. So this is how the cervical ectomy presents. This is cervical erosion. This is cervical loss, and this whole area is the cervical erosion. So how you diagnose? It can be confused with ectropion, early carcinoma of Schenker, that is that appears in herpes, or a tubercular ulcer, which is indurated with caesation at the base. So how we will manage a case of cervical ectomy or erosion? All cases should be subjected to cytological examination to exclude dysplasia and malignancy. So all patients with cervical erosion, they should have a cytological examination, that is, they should have a pap smear to exclude dysplasia and malignancy. In symptomatic cases, if they are taking OCPs, they should be stopped and Benign method is advised. And persistent ectomy with troublesome discharge is treated with cauterization, cryosurgery, or laser vaporization. So this is how we manage cervical erosion. Eversion or ectropion. In chronic cervicitis, there is a marked thickening of cervical mucosa with underlying tissue edema. These thickened tissue tend to push out through the external os along direction of least resistance. So it is more marked if cervix already lacerated, and as a result, tips of the cervix curl upwards and outwards, exposing red-looking endocervix. Cervical tears that usually occur during delivery, vaginal delivery. One or both sides of the cervix may be torn or it may be irregular, stellate shape. If there is no infection, the torn surface is approximate and heal, leaving a notch. If infection persists, it causes eversion. Non-obstetric causes include menstruations due to operative procedures like DNC, dilatation and curettage. Postmenopausal atrophy or chronic cervicitis also predisposes to tears. Cervical cysts are Nepothian cysts, endometriotic or mesonephric cysts. Nepothian cysts, these are the endocervical glands in their transformational zone, which become covered with squamous cells and they form leukocytic cysts. As this benign process continues, more clear or yellow glandular elevations are visible during routine examination. Nepothian cyst warrants no further therapy. So this is cervix, this is speculum. We have inserted a speculum and the cervix is visualized like this. This is cervix, this is the cervical os, and this is the Nepothian cyst. Now the endometric or mesonephric cyst. The endometric cysts, they are situated in the portio vaginalis part of the cervix. A small, reddish, and less than 1 centimeter size. Implantation of the endometrium due to surgery or during labor occurs, which gives rise to the cyst. Symptoms include intermenstrual bleeding, dysmenorrhea, or postpartum bleeding. Treatment is by cautery and rarely excision. Now, the mesonephric cyst, usually situated in the outer side of the cervical stroma, seldom increase in size, lined by the covered epithelium. They are asymptomatic and they do not need any further treatment. So there are three types of cysts: Nepothian, endometriotic, and mesonephric cysts. Now, endocervical polyp. It is a benign condition, common neoplasms, a hyperplastic rejection of the endocervical fold. It may be associated with vaginal discharge and postcoital bleeding or intermittent bleeding. It has a slender stalk which is removed by continuous twisting using a forceps. So twisting leads to occlusion of the supporting vessels and eversion of the mass. A broad start needs surgical excision. Excised cervical polyps require histopathologic evaluation to rule out malignancy. So endocervical polyps, they are treated by eversion and curettage. These are the cervical polyps. This is the cervix, cervical canal, and these are the polypoidal growths protruding through the cervical walls. So what we do, we hold them with a sponge holding forceps, and we keep on twisting until the polyp uh, is broken from its stalk. The inflammatory conditions of the cervix. These are cervicitis. It may be acute or chronic. Cervicitis is an infection of the endocervix, including glands and stroma. So acute cervicitis usually follows childbirth, miscarriage, or any operative procedure of the cervix. These responsible organisms include gonococci, chlamydia, trichomonas, mycoplasma, and papillomaviruses. The patient presents with painful vaginal examination, tender edematous congested cervix, and mucopurulent vaginal discharge, cervical discharge on postpartum examination. It resolves completely, infection spreads to adjacent structures, and becomes chronic. The treatment is the high vaginal endocervical swab to be taken for better examination and treat with epidural antibiotics. So we take HVS, endocervical swab, and send for culture sensitivity, and then we treat with the appropriate radiation. Chronic cervicitis. It follows usually acute cervicitis. Endocervix is a potential reservoir of infection with Neisseria gonorrhea, chlamydia, HPV virus, human papillomavirus, and bacterial vaginosis. So clinically, patient is asymptomatic. Excessive mucoid discharge might be present, and there is history of contact bleeding whenever there is after the coitus or after special examination. When we examine the cervix, it is tender, and on postpartum examination, there is mucopurulent discharge. It is treated. Regarding treatment, there is no role of antimicrobial therapy except in pneumococcal infection and diseased tissues to start with thermic cauterization or laser cauterization. Human papillomavirus infection. It is a DNA virus, and it has over 100 different types and subtypes. So genital HPV is divided into low risk and high risk types. The low risk includes 6 and 11, and high risk includes 16, 18, which are most common, 31, 33, 45, 46, 56 also. So it is a common infection, while cervical cancer is a rare disease. What are the factors that increase the risk of transmission of human papillomavirus? They include smoking, increased parity, early age of intercourse, oral contraceptive pills, and immunity. So those patients who are on suppressive drugs, or they are using OCPs, or they have early marriages, or they are grand multiparas, and smoking. These are the factors which will increase the risk of transmission. So how this virus causes pathology? The zone of transformation is defined as an area between the original squamous and the current squamous junction. So here at this point, epithelium changes from columnar to squamous epithelium over time. It is the site where premalignancy and malignancy occurs. So persistent HPV infection, it leads to an oncogenic process in this region. And what happens? The metaplasia occurs. Integration of this virus DNA into the basal epithelial cells, it will lead to immobilization and rapid turnover of the cells. So this disordered immaturity within the epithelium, it leads to cervical intraepithelial neoplasia. These immature cells are hypochromatic with large nuclei. They have minimal cytoplasm and abnormal mitotic figures. So what happens? This virus, when there is persistent infection, it will lead to an oncogenic process in this region, which will lead to metaplasia and integration of this virus into the basal epithelial cells, and which lead to immobilization and rapid turnover of the cells. So this immaturity within the epithelium leads to cervical intraepithelial neoplasia. And such cells, they have hypochromatic larger nuclei and minimal cytoplasm and abnormal mitotic figures. The role of HPV testing, Papillomavirus testing in cervical screening. It improves the cervical testing if there is HPV positive patient. If we do cervical testing, cervical screening, or colposcopy, it will improve the results. High negative predictive power. It has high negative predictive power. If HPV is negative, the risk of developing cancer over the next 5 to 10 years is exceptionally low. If a patient is negative for virus, then there are very less chances of developing cancer. If normal cytology in 95% of women, they are put on routine recall. If they have high-grade cytology, that is 2% of the patients, they have high-grade cytology, they are referred for colposcopy. So women with minor cytological abnormalities, they undergo reflex testing with high-risk HPV. So HPV negative women, they are returned to routine recall, and HPV positive are referred for colposcopy. In UK, all pap smears are tested first for HPV. So all patients who have their pap smears, they are first tested for HPV. Only HPV test positive are assessed by cytology. So in this way, we are decreasing the burden of doing cytology. We do HPV testing first. If it is negative, the patient is returned to the routine recall. And if it is positive, then we will do cytology or colposcopy. So HPV testing has a major role in cervical screening. Now, what is cervical intraepithelial neoplasia, or CIN? There are two terms, metaplasia or dysplasia. Metaplasia is change of epithelium from one cell lining to another, that is from columnar to squamous. And dysplasia is abnormal epithelial cells that fail to mature. So they have hyperchromasia, larger nuclear size and larger nuclei, variable sizes, and they have increased mitosis. So this is dysplastic growth, while metaplasia is change of epithelium from one cell lining to another. So whenever there is cervical intraepithelial neoplasia, it may either undergo regression or progression. So it may be mild, moderate, or severe. Mild is CIN1, moderate is CIN2, and severe is CIN3. Low-grade disease. In such patients, regression occurs through patient cell-mediated immunity. And if it is high-grade disease, it is less likely to regress and it requires treatment. So cervical cytology is classified as low-grade or high-grade. Low-grade means minor cytological abnormalities showing minor dyskaryosis or borderline changes, while high-grade shows moderate to severe dyskaryosis. Cervical cytology triages patients to colposcopic clinic for further assessment. So first of all, do HPV testing. HPV positive, they are done cervical cytology, pap smear, that is also called pap smear. And if on pap smear, if it is grade, then there is moderate to severe dyskaryosis, and the patient is referred to colposcopic clinic for further assessment. CIN is abnormalities in the surface cells of the cervix that may become cancerous. So CIN is not a cancer. It has 3 grades, 1, 2, and 3. 1 is low grade, mild dysplasia confined to the basal 1/3 of the epithelium. CIN2, high grade intraepithelial lesion, high cell. Moderate dysplasia confined to the basal 2/3 of the epithelium. 3 is high grade intraepithelial neoplasia, severe dysplasia, and more than 2/3 of the epithelium is involved. So this is how we classify CIN 1, 2, 3. This is CIN 1. Only 1/3 of the basal epithelium. CIN 1, mild dysplasia. CIN 2, moderate dysplasia. More than, it is about 2/3 of the epithelium which is involved. And CIN 3, severe dysplasia. And more than 2/3 of the epithelium is involved. And this is invasive cancer in which the basement membrane, this is the basement membrane, which is broken. And these cells invade the subepithelial tissue. Now, what will the outcome of CIN? It causes either spontaneous regression or it may progress to aggressive cancer. Progression from one stage to another takes years, and reduction in treatment of CIN prevents the cervical cancer. So screening for CIN is done by cervical smear, which is also called pap smear. Screening for dyskaryosis by obtaining cervical cytology. Cervical screening should be carried out every 3 to 5 years in non-section active women from age of 20 to till 60 years of age. And 95% of the women, they have normal cytology. When we screen, we do pap smear, 95% they have normal cytology. Abnormal cytology shows squamous cells at different stages of maturity, that is dyskaryosis, which may be mild, moderate, or severe. This is how we do cervical screening. This is uterus, and this is vagina, and this is the cervix. We introduce this speculum, and this is the cytobrush. We rotate this brush through 360 degree, and we take the smear from the active cervix, and later it is spread on this glass slide. All this brush is inserted into a liquid, and then it is later sent to lab for cytological examination under microscope. So this test is called pap smear. So how we manage? The report will come either normal, inflammatory, or borderline. There will be mild dyskaryosis, moderate, or severe dyskaryosis. So this is how the smear results will come. Either it will be normal, which is in about 95% of cases. If it is normal, we will repeat it 3 to 5 years. And if smear is negative, then we will do routine testing only. If it is inflammatory, we will give antibiotics and repeat after 3 to 5 years. And if it is borderline, repeat after 6 months. Repeat 1 year then, and after 2 years, then routine testing. And if 3 borderline results come, then we will refer the patient for colposcopy. If CIN1 mild scoliosis, then we will repeat after 3 months and repeat after 1 year and then 2 years and then routine testing. If moderate scoliosis, that is CIN2, then we will refer for colposcopy and repeat after treatment. If severe dyskeriosis CIN3, then we will refer for colposcopy and repeat after treatment. If it is invasive, invasion is suspected, then we will do urgent colposcopy and biopsy. What is colposcopy? It is the direct visualization of the cervix through a low-powered microscope. It magnifies the cervix 4 to 20 times. Patient is put in the thoracic position, and the spectrum is inserted, and the cervix is visualized with the help of colposcopy. We can directly visualize the cervix, or we can inspect by a colposcope. We'll study its vasculature, the pattern of the vessel. Here is a clean filter which may help in studying the vasculature. Abnormal vascular structures include punctations and muscles. So there are 2 tests which we can apply during colposcopy: acetic acid test or Schiller test. We apply acetic acid to the cervix, 3% acetic acid. It strains the abdominal area and the area the nucleoproteins they are coagulated, and acetic acid covers these nucleoproteins and these areas appear as white. So these aceto-white lesions are the abnormal areas. While Schiller's test is another test in which nucleotide is applied to the suspicious area. This affected area, it lacks glycogen, so there will be no staining of the cells. There will be no brown staining of the cells, which we call iodine. While the normal cervix stains brown. The colposcopy gives a clinical diagnosis, and punch biopsy from the abdominal area gives a histopathological diagnosis. So now you understand what is called a colposcopy. Colposcopy is a scope with the help of which we directly visualize the cervix and we study the vascular pattern. We apply 2 tests, that is acetic acid test and Schiller's test. We will outline the abnormal areas. This is this whole of the cervix, and this is the cervical os, and you can see over here, this is the aceto-white area. So this is the abnormal area. When acetic acid is applied to this area, what happens? There is coagulation of the nucleoproteins of these abnormal cells, and these appear as white lesions. So this is the aceto-white lesions by the acetic acid application. Again, this is aceto-white area with raised and rolled over edges and outer margins. It is close to the squamous junction, and this lesion is extending inside the cervical canal. Now, if on colposcopy there are abnormal areas, acetocyte lesions, or leukocyte test is negative, that is, there are no round areas, then it means that is an abnormal area, abnormal findings on the colposcopy. So there are certain management options, either excisional or ablative methods to treat the abnormal colposcopy findings. Excisional include loop electrosurgical excision procedure, and carbon dioxide laser cone biopsy, and hysterectomy. So these are the surgical or excisional procedures. While ablative include radical electrodiathermy, cold coagulation, cryocautery, and laser. The 90 to 95% of the patients, they have cured their disease by these procedures. So what are the diagnostic tests? Pap smear, HPV testing, while punch biopsy, endocervical curettage, bone biopsy, and lead, they are both diagnostic and therapeutic or treatment options. This is sleep. This is cervix, and this is the abnormal area, respiratory area, and this is the leap instrument. There is a receptoscope. Receptoscope. So this wire causes removal of the abnormal area. So with the help of this wire, this abnormal area is shunned. This is central histopathology. Human papillomavirus vaccine. It's the first vaccine that aims to prevent cancer and to save. The two forms of vaccines, bivalent and quadrivalent. The bivalent prevents infection with HPV 16 and 18, and quadrivalent prevents infection with 6, 11, 16, and 18. So it should be given to all patients with reproductive age. This is the flow chart. This is the flow chart which shows management of pap smear. So class 1, this is either the pap smear is normal, either it is inflammatory, or it is class 3, that is CIN1, CIN2 or 3 moderate to severe, or it is invasive carcinoma. So there are 3 types of results which you can find on a pap smear report. If it is normal, the report is normal, repeat yearly after 3 years, and then 3 to 5 years until 50 years. So we have to do after 3 years. If it is inflammatory, then treat the infection. You can give antibiotics and repeat pap smear in 3 months. If the repeat result is normal, we will follow as class 1. And if it is persistent infection, then you have to again repeat after 3 months. Now, if it is class 3, that is CIN1, low grade intraepithelial lesion, test for human papillomavirus and follow up yearly. Then we will do HPV testing. If it is normal, routine care, and if it is persistent infection, then treat as high cell. Now, if it is moderate to severe CIN2 or 3, Then we will refer the patients for laparoscopy urgently and a biopsy. If on colposcopy, there are three options after biopsy. If it is confirmed CIN2 and 3, then we can do conservative ablation, local excision, or radical excision. So it depends. If it is conservative ablation, then it can be done with coagulation, cryosurgery, and laser ablation. They have lifelong follow-up. If we do local excision, it will be help of bone biopsy, laser quantization, large loop excision transformation zone or LEAP, large loop excision of the pathological area or nets. So local radical excision it includes the cone biopsy, trachelectomy where whole of the cervix is removed, hysterectomy with or without removal of the vagina. So all these patients they require follow-up. Radical after radical excision, after local excision, after conservative ablation. All they need lifelong follow-up. So this is how you will manage a patient with CIN or pap smear. If it is normal, you will do as 3 to 5 yearly pap smear. If it is inflammatory, then you will treat the infection and repeat inflammation. And if the repeat smell is normal, we will do routine follow-up. And if it is persistent infection, then we will repeat the smear and then if there is persistent infection, then we have to do conservative ablation procedures or local excision. In class 3, that is low cell CIN1, we will do HPV testing. If it is negative, then it is normal, or if it is persistent HPV infection, then we treat as cancer. And in moderate to severe, we will refer for colposcopy and biopsy and treat according to the report of the biopsy. In class 4 invasive carcinoma, which is treated according to the stage of the disease. So the key points or the take-home messages: benign diseases of the cervix are harmless, but malignancy should be excluded. Cervical intraepithelial neoplasia precedes cancer cell years. CIN1 may progress to CIN3 in 20 years. While screening for CIN reduces mortality from cervical cancer, so all patients they should be screened with pap smear. Those with positive screening tests should be referred to pathology for diagnosis and treatment. So this is all about the benign and pre-malignant diseases of the cervix. So thank you to be with me. I hope you can understand a bit, although it's a little difficult. It's not a straightforward topic to understand. It is a little difficult. So you have to concentrate more. What is CIN1, CIN2, CIN3, and what is low grade, high grade lesion. So first of all, you must know how to classify the cervical intraepithelial neoplasia and how what are the diagnostic tests which can be applied and how you must treat this cervical intraepithelial lesions. So thank you very much to be with me. So if you have any questions, you can ask. Learning objectives. This is introduction. This is epithelium of the cervix. This is in the childhood period, columnar epithelium inside and squamous outside in the active cervix. In childbearing reproductive age, this columnar epithelium, this pink epithelium outgrows. And here in the postmenopausal women, it goes inside. This squamocolumnar junction goes inside, recedes inside the endocervical canal. Then you must know what is zone of transformation. Transformational zone is the area between the old and new squamocolumnar junction. So this is the most dangerous zone where the malignancy can occur. This is zone of transformation. This is the squamocolumnar junction, new, and this is the zone of transformation. And in this area, there is risk of developing the malignancy. Benign diseases of the cervix. They include cervical ectopy, eversion, tears, and cysts, and endocervical polyps. While the inflammatory conditions of the cervix, that is cervicitis, it may be acute or chronic. This is cervical ectopy or erosion in which the columnar epithelium goes outside, and it presents with vaginal discharge, sometimes bleeding, and associated cervicitis may occur, which may lead to back pain. It may be due to hormonal changes during pregnancy or hospice users, or it could be due to infection that is chronic cervicitis, congenital. So this is cervical ectopy. This is how you will see cervical erosion. This is cervical canal, and this whole area is cervical ectopy or erosion. So how the differential diagnosis is can be confused with ectropion, primary chancre, early carcinoma, tuberculosis. So we must do a pap smear or colposcopy to rule out these conditions.